Welcome, everyone. It's my distinct pleasure to introduce Dr. David Swerdlow, who is a senior fellow at the Center for Communicable Disease Dynamics at the T.H. Chan Harvard School of Public Health. We have interacted with David for a long time, so it's a pleasure to have him back talking to all of us again after a while. David recently retired from Pfizer Vaccines after 6 years as Global COVID Vaccine Medical Lead and Clinical Epidemiology and Business Development Lead. He also worked before that at CDC for 25 years. From 2009 to 2015, he was the Associate Director for Science, National Center for Immunization and Respiratory Diseases. He was an incident manager, CDC lead for CDC's MERS response in 2014 and held leadership roles during numerous other CDC emergency responses. David is board-certified internal medicine and infectious disease expert and was a clinical assistant professor of medicine at Emory University and worked in the Infectious Disease Clinic in the Atlanta VA Medical Center from 1993 to 2015. He has done amazing work in this area. We had the distinct pleasure of working with David during the previous pandemics. For instance, he was a co-chair for the Pandemic Prediction and Forecasting Science and Technology Working Group that was sponsored by the White House Office of Science and Technology Policy. With that, David, welcome again. It's a pleasure to have you and meet you after a long time, and we are really looking forward to the talk.
Thank you so much for that very nice introduction, and I really am excited to be here. I've wanted to make a talk like this for a while, where I looked back on my whole career since I got involved with modeling. And so I was very happy when Steve asked me to put this together. So as you heard from the introduction, I was at CDC where I led a modeling unit. That's where I got to work with some of you. Then I went to pharma. I was at Pfizer. And then I left Pfizer and became a senior fellow with Mark Lipsitch at CCDD. But then just like a week ago or a week and a half ago, I actually took on another position back in pharma at a vaccine manufacturer. But I'm going to, as of now, I'm going to continue to be a senior fellow at Harvard. So I thought, in a way, I think I do have a relatively unique perspective on modeling from many different perspectives, public health, pharma, and now a little bit with academia. So this was a slide that anyone who saw my work or our work at CDC has probably seen. But this is a slide I used to show when I was at CDC. And it was our model for modeling in public health. And the idea is that the epidemiologists had to be close to the modelers. And the epidemiologists provided data, parameters, assumptions to the modelers. The modelers helped with study design, questionnaire design, and of course, analysis. And then the epidemiologists and the modelers both worked to help influence policy. And I think that the critical thing that I learned when I was at CDC was that the modelers had to be close to the program. And we felt that when modelers were working directly with us, that was the most effective way to be able to do good models that were influential and important. So I am going backwards. Again, I'm going to be talking about sort of my whole experience. So that started with 2009 H1N1. And these are all slides that I had back then. But, modeling helped answer a lot of critical epidemiologic questions. So the modelers helped us, the epidemiologists, with some very important questions. So the main questions that I'm just going to mention today are severity, efficiency of transmission probability and dynamics, and burden of illness. And again, the theme is epidemiologists and modelers working together. So at the very beginning of the H1N1 pandemic, there was a lot of concern because on the nightly news, all you saw was dead bodies, not to be blunt about it. That was all you heard about was the severe illness. And people were really very worried at the beginning about what the severity of the new influenza would be. And so between a combination of epidemiologic studies and modeling studies, we think we did have some impact on the understanding of severity. And sometimes, in my eyes anyway, there's a fine line between epidemiology and modeling, and there's some crossover. So this was a supplement to clinical infectious diseases that we put out that included field and epidemiologic investigations, but it also included several modeling studies. And so the editors were myself and my wife, who I'm sure many of you have worked with as well, Lynn Finelli. This was an early investigation that we did. CDC experts called to University of Delaware after swine flu confirmed, so that they were still calling it swine flu. That was the first university outbreak. We did a lot of field investigations, some with modelers. One of the things that we did in Delaware, as well as Chicago, is we did surveys. So in Delaware, we interviewed all the students and all the staff. In Chicago, it was a community survey. And so we put that all together as a way of thinking about severity for the 2009 pandemic. So this slide shows severity of illness from the Delaware surveys and the Chicago surveys in 2009. So on the far left, you can see ILI per 10,000, hospitalizations per 10,000, and deaths per 10,000. And then you see columns from Delaware and Chicago. So those were from our surveys. And then you see what would have been predicted if what people say about the attack rates and the case fatality rates from 1918 and 1968 are true. So the first row is ILI per 10,000. And so from the surveys, we determined that about 1,000 people, a 10% attack rate was reported from Delaware. About a 5% attack rate was seen in Chicago. Whereas in 1918 or 1968, the attack rates were much higher. So that's just attack rate. But in terms of severity, you can look at hospitalizations and deaths. In particular for deaths, in those surveys, and then we also went into the community and went to the hospitals, looked at death records, we didn't identify anybody who had died. So the bottom row is 0 deaths per 10,000 from Delaware or Chicago. Whereas if this had been 1918, we would have predicted 60 deaths and 7.4 deaths. So this is all data to suggest that the illness from 2009 was not as severe as previous pandemics. Greg Armstrong and Lynn also did a model, which was published in that supplement I showed you, looking at timely assessment of the severity of the outbreak. And they used 122 cities mortality reporting system, which is urban areas submit to CDC total deaths as well as PNI, pneumonia and influenza deaths. And then they modeled excess weekly mortality in real time. And it was age specific. And then they compared it to previous pandemics and seasonal influenza. So again, weekly excess mortality. So this is one of their graphs. This shows all age groups. They also have it for different age groups, which is also interesting, but I'm not showing that here. So on the left, you can see cumulative excess deaths. So this is cumulative over the season, but it is by week. And you can see this purple line at the top is 1968, 1969, which was a pandemic. And so that would be sort of the pandemic range of severity or excess deaths. That orange line is a bad H3N2 year. And so they broke everything down into pandemic range, H3 range, H1 range. And the black lines were the pandemic ranges for H1N1. So you can see that the severity was not nearly as high as previous pandemics. And in fact, not even in the H3N2 range. So we thought that this was again, useful information for thinking about severity. Then the next question we had was about transmission efficiency and transmission dynamics. This was a paper that was led by Simone Kushmez, who I'm sure you all know, and Neil Ferguson and Lynn. And so they used CDC National Case Report form data to be some of the first people to identify what the serial interval was. They determined from household transmission rates that the transmissibility was lower than that in other pandemics. And they also found that household contacts less than 18 years old were twice as susceptible than older persons. So all very interesting parameters for understanding the H1N1 pandemic. This was also another paper that was from our supplement that Crystal Donnelly, I'm sure you all know, did. And she took all of the field investigations that we had done and she combined them all and came up with some estimates of serial intervals and temporal distribution of secondary infections. And so the graph I show here shows the probability of transmission on the y-axis, and then the days since symptom onset on the x-axis. And so you can see that this was very useful information when thinking about when people transmitted H1N1 to other family members. So you can see that there was some transmission even before symptomatic. This was also very useful for thinking about when people could go back to work and that sort of thing. So this was very useful modeling for control measures. This was a really fun investigation that Simone worked on. Again, he was seconded, he was embedded in our group, and he helped with all aspects of the field investigation. And it was a very interesting investigation. It was the first school that had been affected by the pandemic. And we actually went throughout the school and interviewed every child and created these very interesting social networks and then tried to figure out gender mixing patterns and who infected whom. And so you can see here, the girls are in the red and the boys are in the blue. And this was a very interesting social mixing. And boys infected other boys, you can see from this. And girls infected other girls, except this one boy over here. We don't know exactly who he was. And then we also looked at infectivity in the school was much quicker than in the household. We also found that late school closure had no noticeable impact on spread. If you're going to close schools, you have to do it right away. So this was a fun investigation, and we learned a lot about social networks and transmission. So then the last thing I just want to mention from the old days was our attempts to understand the burden of illness. And so we had two models during the pandemic. One was early on and one was later on. And this slide just shows the disease indicators. We used percentage outpatient visits in ILINet. So in other words, this is just what we learned from influenza-like illness in the community to indicate where the pandemic was. So here was the first wave and here was the big October wave. So we used two different models for various reasons, one at the beginning and one towards the end. And so this was the pyramid model. We actually based it on a model that we had created years ago to look at foodborne illnesses, where you figured out the multiplier in between each layer. So what proportion of people go to the doctor, what proportion of the doctors order tests, what proportion of those tests are reported, that kind of thing. So we created a model that was very similar to the foodborne model. And it was very important because based on laboratory confirmed cases of flu, there were only 43,000 cases reported. And after 43,000, actually they stopped counting. So they no longer kept track of individual cases, which is very different than COVID. But after 43,000 laboratory confirmed cases, the case counting stopped. We used other methods to think about the burden of disease. But we said those 43,000 cases was surely not really what's going on. And in fact, the press was saying, what's the big deal? There aren't that many cases. Why are you guys all getting so excited about this pandemic? So we created a pyramid model using data from other sources to think about what proportion of people were asymptomatic, what proportion were symptomatic. Among the symptomatic, what proportion went to a doctor, how many were hospitalized, and how many died. And you can see on the left, for example, there were 43,000 cases reported, but we think that there were 1.5 million medically attended cases and 3 million cases of symptomatic illness. And that was a big deal. In fact, it was mentioned in the press. And it led to a lot of excitement when people said there were 3 million cases, when we had been saying that there were 43,000. So it was an important way of really understanding the true burden. But in the second half of the pandemic, we couldn't do that because we weren't keeping track of the number of laboratory confirmed cases. So we had to use other methods to think about what the burden was. For that, we used a method that was based on hospitalizations. And we knew how many hospitalizations there were from the Emerging Infections Program in the United States, which kept track of hospitalizations in certain parts of the country. Up here on the left, it says hospitalizations reported to the Emerging Infections Program. We then extrapolated that to the US population. And then we determined that the multiplier was 2.7. So we thought for every hospitalization that was reported, there was actually 2.7 more. And that led us to the total number of hospitalizations. We then knew, depending on the age, that 6% of hospitalizations died, or 1.5, depending on the age. And then we knew among the hospitalized how many total cases there were. We calculated that that was 222. So we came up with this estimate then for the total number of cases that had actually occurred from H1N1. So we calculated that there were 12,000 deaths, 274 hospitalizations, and 61 million cases. So that's obviously a lot more cases than was really appreciated or known about or reported. So I think, this was an important study with attack rate about 20%. So then while it was still at CDC, we also were worried about a variant virus called H3N2V that was seen in people who attended agricultural fairs where kids would go and show off their animals, et cetera. And so we did a whole clinical infectious disease supplement. One of the studies in this supplement was a very interesting model. At least we thought it was interesting. You can see it actually here on the cover. It was an SEIR model in humans and an SIR model in swine. But we really created a whole compartment model for the swine and a compartment model for the humans. And then we figured that the infected swine would be infecting the humans. And so these are all the parameters that we used and how we came up with the parameters. So total number of humans with swine contact, number of swine, number of infected humans, number of infected swine, et cetera. And we created a whole model to determine how many people had actually been infected at the fair. During the same time period where we were worried about H3N2, Simone came up with a whole way of thinking about how you can use surveillance data to estimate the epidemic potential of emerging zoonoses. So we were getting all these reports of these individual cases of people with H3N2V, this variant H3N2, swine variant. So he really came up with this whole model of how to use that information to think about what the true epidemic potential was. And the way he did that was by thinking about the proportion of the cases that were directly infected by swine. So if you hear about a patient and you go to them and you say, "Did you have swine contact?" and they said yes, then they would be this top row. And that would be the length of the chain was 1 because the person had contact with the swine. But then let's say you went and you found 2 people and only one of them had had contact with swine, then only half of those people had direct swine contact. And so that tells you something about the length of the chain. And then let's say you had 3 people and only one person had swine contact. That would also tell you something about the length of the chain. So, it seems obvious, but if you interview 100 people and nobody has association with the pig, then you know that there's human-to-human transmission going on. Whereas if you interview a bunch of people and they all have exposure to the swine, then it's more likely that there aren't long lengths of chains. And then from the length of the chain estimate, you can estimate the reproductive number. So this was a very interesting study as well. So then towards the end of my time at CDC, we had our third supplement, and it was CDC modeling efforts in response to a public health emergency. And we used H7N9 as an example. So we just said, let's just say there's a mild to moderate or moderate to severe influenza pandemic. We used H7N9 as just a model. How many hospitalizations would there be? How many deaths would there be? More importantly, how many ventilators would you need? How many surgical masks would you need? Would school closures make a difference? Would a vaccine impact a one-wave pandemic? This was published in 2015. Some of this I think was pretty prescient for the COVID pandemic. We recognized that we wouldn't have nearly enough surgical masks or ventilators, et cetera. So this is a slide from this analysis. It says the timing of infection and vaccination. Would you be able to have a vaccine program impact a one-wave pandemic? I mean, that's critical, that we're only talking about one-wave pandemics here. So on the left, you can see persons infected. This says H3N2V, but it could have been any influenza. So persons infected, and then the solid lines are the numbers of people infected. It's based on R0. So here R0 is the black line, R0 is 1.5, and this is 1.3, and then this one is 1.1. And then these dotted lines are the doses administered and the people protected, which lags a couple of weeks. And so you can see that with a pandemic that at an R0 of 1.5 or 1.3, if it was a one-wave pandemic, you really wouldn't be able to get doses into people in time to make a difference. This was with flu. You know, it was much easier to make a new strain of a flu vaccine than a new coronavirus vaccine. But the point was you would need to act very quickly to be able to make a difference. One of the things that we found was that one of the bottlenecks was fill and finish capacity. And we presented this to BARDA, and apparently BARDA did have an effort to increase the fill and finish capacity for pandemic vaccines. So then I moved to Pfizer. A few years later, we got the first reports of SARS-CoV-2. We wrote this paper. It was in JAMA that was before it was even called COVID. It was written at the end of January 2020, published online February 11th. So that was 2 weeks before there'd been a single death in the US from COVID. But, you know, we pointed out that the 2009 influenza pandemic was transmissible but not severe. SARS and MERS were both severe but not transmissible. But that the novel coronavirus reported from China seemed at that time anyway to be severe and transmissible. And we said that a transmissible virus would be very difficult to contain, and that we would likely not have adequate ventilators and masks, et cetera. And so our final line was effective prevention and control will not be easy if there's sustained transmission, and will require the full attention of public health, federal, local governments, the private sector, and every citizen. And that certainly came to be. We wrote a paper with Mark about defining the epidemiology. So this wasn't really, well, there was some modeling discussions in this paper as well. Again, this was very early on in mid-February, talking about what kind of evidence you need for controlling things like household studies, community studies, the severity pyramid, risk factors, et cetera. So again, this was pretty early on. So then I wanted to spend the rest of the time talking about how we used modeling in pharma. The first three bullets are ones I don't have any slides for. I'll just talk about. The other ones, I do have some papers that we published. But the first three were more internal discussions, but they were incredibly important. And we went back to some of the modelers that I had worked with before at CDC, like Jeff Shaman and Mark Lipsitch and the University of Utah. And we collaborated on a bunch of modeling papers and studies. So the first three, as I mentioned, are ones that were critical for the clinical trial. So we worked with Jeff Shaman and others to be able to predict the attack rates that there would be for the clinical trial. In particular, you know, when should we do the trial? Where should the trial take place? So those were more internal discussions. Then what were the current levels of immunity and when will we reach herd immunity? That was important for our program. What happens if, you know, at that time, people before the variants, I think, and before we understood waning immunity, we actually thought that we could reach a level where you would have herd immunity, and maybe the vaccine wouldn't even be needed. So we wanted to think a lot about levels of immunity, and so I'll show you some things we did on that. We did a lot of work on county level predictors of disease activity early in the pandemic. And then we did a repeat of that study looking at the impact of vaccination. we said, could you relax non-pharmaceutical interventions after the vaccination campaign was begun? So what happens if people start getting vaccinated and they stop wearing masks or stop social distancing? We modeled that. We modeled vaccination strategies in nursing homes. We started off with thinking about, should the residents be vaccinated or should the staff be vaccinated? But then we wound up coming up with some other findings. And then we worked a lot in Israel looking at vaccine effectiveness in averted cases model, because as you know, Israel was the first country to have a large vaccination campaign, and it really had a tremendous impact on the pandemic at that time. And so we did a lot of work with looking at effectiveness and how many cases we averted. So this was a paper that we published when people were talking about reopening society. We had the initial lockdowns in March, and people were starting to think about reopening society. And we said, you really need to be careful about that. We really need to have real-time incidence and seroepidemiologics data. Cross-sectional community surveys were important, et cetera. We really needed to know what the levels of immunity were before you just suddenly throw off all the non-pharmaceutical interventions. And so then we followed that with our own estimates of the levels of immunity. And we created, again, this same pyramid model we had done for H1N1 and for foodborne diseases, and came up with our estimates of what the immunity was. And we had different multipliers depending on whether you were looking at symptomatic disease or actual infections. And the multipliers changed. So at the beginning, there wasn't very much testing. So we thought the multiplier was about 6, whereas towards the end of our study, this was November 2020, by the end of November 2020, there was a lot more testing. The multiplier was down to 1.9. So we had to use a sort of a time-specific multiplier. But in the end, we came up with our estimations of what proportion of the population was infected. We thought about 14% of the population was infected. And, we came up with some estimates of the numbers of deaths, et cetera. So then we basically repeated this same study back then in August of 2021. Because again, at that time we were thinking, what's going to happen? Have we reached immunity? Would there be further outbreaks? And if you look on the lower left, you see that we used CDC seroprevalence estimates by state. Then we calculated an underreporting multiplier for each state. We estimated the number of infections on July 5th for adjusting for underreporting. And then we estimated what proportion of the population was immune out of the entire state. So we did that from natural infections. Then we added in the vaccination, of course, taking into account the background levels of natural infection immunity. And then we came up with an estimate of the total population immunity. And so we found that the population immunity from natural infection and from vaccination varied greatly. And 19 states had less than 60% of their population immune from vaccine or infection. So we predicted that there would still be an opportunity for a lot of disease. Then I mentioned that we did the 2 studies that were similar, one at the beginning and one more recently, where we looked at county level predictors of coronavirus disease. This study was until August of 2020, so sort of that first portion. And we found that rates of disease were higher in counties that were more urban or densely populated, or that had more crowding, air pollution, more female persons aged 20 to 49, racial ethnic minorities, a high proportion of the county, residential housing segregation, income inequality, uninsured persons, diabetes, or mobility outside the home. So this was looking at what were the factors associated with having high number of cases. Again, this was before vaccination. So we repeated that after we had vaccine. And so this was county level vaccination coverage and rates of disease. Again, we did a complex analysis, including all the county level environmental, socio-demographic, economic, and health status related characteristics. This graph is a little bit hard to understand, but basically we said the percent relative reduction in counties based on their vaccination levels. So over on the far right is deaths and cases. And this was in counties where over 80% of the population had been vaccinated. They had a 30 to 46% relative reduction in cases and deaths. Whereas in counties with 50 to 59% of the population vaccinated, it was a relative scale. So that was 0. So then we were working on modeling some aspects of vaccination and whether you should still do social distancing with Jeff Shaman. And so we published this letter to Science just sort of to get the information out there. So it was just a letter, but it said social distancing remains key during vaccinations. And we felt that even if you're vaccinating, if you get rid of social distancing, you're going to still have a lot of cases. Part of it is just because of how long it takes to get the vaccine into people, given availability, et cetera. But then we followed that with a full article and looked at how non-pharmaceutical interventions, inoculation rates shaped the vaccination campaign success. And so this is a little bit complicated, but on the upper left is showing the millions of persons vaccinated by date. And so the vaccination program started in the middle of December 2020. And then the different colors are the different numbers of vaccines given per week. So if there were 13 million per week, then it was this light blue line. And if there was 3 million per week, it was this dark blue line. And then in this upper right-hand side shows infections averted. And then on this axis, you can see no NPIs and then high NPIs. And so if you look over here, then you can see, let's see now, for the scenario where you have 3 million vaccines per week and you have no NPIs, then you're not going to avert that many cases. In this setting where you have high vaccine delivery and high non-pharmaceutical interventions, you had a much higher number of infections averted. So basically, this showed that it was both the rapidity of administration of the vaccine and how well you stuck to NPIs that made the difference. And then this was a study with Matt Seymour and his group from University of Utah, where we were looking at long-term care facilities. They had a model that they had already had developed for long-term care facilities and hospitalizations that they had made previously, looking at other pathogens. And so we just sort of tapped into that model. And again, we showed that there was continued need for non-pharmaceutical interventions, even after you start doing vaccinations. If you look at hospitalizations, for example, or deaths here, or hospitalizations, you can see that depending on the level of strong, gradually reduced, weak adherence to NPIs versus baseline where there was no vaccine. So here's hospitalizations. You have good NPIs, not so good NPIs, but vaccination. And here you have baseline is no vaccine, no NPIs. Then you can see that obviously there are fewer hospitalizations if you have both NPIs and vaccinations. And then this was a paper that we wrote on the vaccine effectiveness. This was one of the first real world reports of the vaccine effectiveness of Pfizer's vaccine in Israel. Again, Israel had a tremendous vaccination campaign at first, and we were able to show that the vaccination program had a big impact on disease. And then we were able to look at vaccine effectiveness. So we looked at SARS-CoV-2 infection, asymptomatic infection, symptomatic COVID, hospitalization, severe, and death. And we showed that for almost all these age groups, the vaccine effectiveness was very high, especially for symptomatic infection, hospitalizations, and deaths. Of course, this was before variants and this was before waning immunity, but at the time we were all very hopeful. So then we did another model to calculate how many infections, hospitalizations, and deaths were averted by the nationwide campaign. In this paper, we looked at the averted deaths. So infections, hospitalizations, severe, and then COVID-related deaths. And you can see without any vaccination, how many deaths there would have been, and with vaccination, how many deaths there were. And so then finally, my last slide is from, again, as I mentioned, I joined Mark's group as a senior fellow. And this slide is a paper that hasn't been published yet, but we put it up on the preprint server. And we looked at the opposite of an averted deaths model. We looked at how many deaths occurred because people did not get vaccinated. So it's the opposite of an averted cases or averted deaths analysis. It's how many people died because they didn't get vaccinated. And CDC and others have published data that have suggested, lots of people died because they weren't vaccinated. And people made what I thought were just, sort of off the cuff estimates on Twitter and elsewhere. But we try to quantify it. And we actually did use CDC data that's publicly available to look at week by week and age group, what the attack rates were for death among people who were vaccinated and not vaccinated. And so by doing it by age group and week by week, we took into account a couple of things. One is changing vaccination rates, and the other is changing attack rates, changing disease prevalence, and then came up with some summary numbers. And I guess the bottom line is from CDC's data, which is from 26 jurisdictions, there were 94,000 excess deaths. If you extrapolate that to the US, there were 156,000 excess deaths. But this was from May 30th to January 1st. We chose those dates because we thought that by May 30th, there was enough vaccine around that if people wanted to get vaccinated, they could have gotten vaccinated. And January 1st was the latest when this data was available. Again, this has not been published yet, but we think it is important to say not getting the vaccine has led to at least this number of deaths. Finally, what questions can modeling answer now? I think some of the questions that I think are important is the overall direct impact of the whole vaccination program, the indirect impact of the vaccination program through herd immunity or decreased transmission, modeling the impact of waning immunity and what's going to come next, the impact of future escape mutants or variants. Will SARS-CoV-2 become endemic? If so, will it be seasonal? And then a couple of questions about some other respiratory viruses. What will be the impact on RSV disease? Since there was such little amount of RSV disease for many infants going through their first year of life, therefore they're not immune. And so will they have more severe disease in the second year of life? Because normally they would have gotten sick in the first year. And then what will be the impact on influenza? So those are my thoughts. Again, it was fun putting this all together as a retrospective. I'm thinking about how we used modeling when I was at CDC and how we used modeling when I was at Pfizer, and then now beginning to do some modeling at Harvard.
Thank you very much, David. This was absolutely beautiful talk. Stephen is back as well. So I'm going to let Stephen be the coordinator for the question and answer session. I'm sure a lot of folks have questions. Raman has already raised his hand, but I'll wait for my turn to ask questions. Stephen, over to you.
So if Model gave me this opportunity, I'm going to ask the question first. I was particularly interested in your analysis of excess deaths among the unvaccinated. And I'm wondering if you think we can apply that to the rest of the world now, because, there's going to be a lot of agitation to say that this thing is over, and it's not over in the rest of the world. And maybe information like this could help make the case that we need to keep working on it.
Yeah, I think that's really important. The data that we had was specific to CDC data, but I think there are other countries that have similar data. I know Canada has some data that's pretty similar. That they have these 26 jurisdictions where they collect information on all the deaths and find out if they were vaccinated or not. And then we were able to look at the attack rates in the vaccinated versus attack rates in the unvaccinated. And what I should say, what we did is we subtracted the attack rates in the vaccinated from the attack rates in the unvaccinated, with the thought that some people were going to die anyway, whether they were vaccinated or not. So we sort of can't hold that against the unvaccinated group. So we subtracted the deaths that would have occurred anyway based on attack rates from the vaccinated, from the unvaccinated. so that we could come up with sort of here's the number of deaths that occurred above and beyond what would have been expected. But anyway, I do think this is I think it's powerful. Our preprint was quoted in the New York Times. I think it's powerful. Otherwise people just don't really have a good quantitative way of saying, yes, there was an awful lot of deaths that occurred due to vaccine hesitancy. And I think it's important. There are things you can argue about this data. You can't prove that every single person who died who was unvaccinated would not have died if they were vaccinated. You can't prove that. People who are vaccinated and unvaccinated have different behaviors. So, it's not perfect. If it's not 156,000, then it was 154,000, but it's still a large number. And I do think, I don't know if the methods can be used, the same methods elsewhere, but I do think it's an important model to look into elsewhere in the world.
Thank you for that. And now I'll let others have some fun. So Ramanan?
Thanks, Steve. Great talk. This is such an exciting overview of so many different topics all covered in one. My question is far more specific. Have you modeled anything to do with hybrid immunity, which is immunity either through exposure or through vaccines? So here, of course, you have vaccination information, but it seems to be, at least on the face of it, that what places like Hong Kong are facing is a combination of high-risk populations not being vaccinated, especially the much older age groups not being sufficiently vaccinated. But more importantly, the fact that exposure in the past has been high. What might you speculate for China, which has had, from what we can see, extremely low population exposure to the virus, and of course, vaccination with a less than great vaccine? What might spread of Omicron through that population really look like?
I mean, that's what we tried to do with this paper, where we tried to take into account both natural immunity and vaccine immunity. But I agree 100%. I think populations where there has either not been vaccination or not been disease are at risk now. Of course, it's great that they avoided having the disease until now, but it does keep them more at risk. So, there's all these issues about, immunity and which is better, vaccine versus natural, and waning immunity and which wanes first. And, is it waning for severe disease or is it waning for just infection? And I mean, there's a million questions, but, I think that just understanding what the basic population level immunity is, whether it's from infection or from vaccine, is critical. And I think it does have implications for certain countries. Here we said it was by state. So we said these states are more at risk, but you can do the same kind of an analysis for countries.
Right. And yours is also Delta. I mean, I'm not sure about this narrative that Omicron is less lethal, because we saw completely different sorts of outcomes in places like India and South Africa versus Hong Kong, for instance, where it seems to be filling up hospital and emergency rooms quite a bit. So, of course, controlling for exposure is hard because we don't know who's been exposed, but at least controlling for the vaccination status does make a difference.
Yeah, and I think it's a critical question, which, I mean, Bill Hahn has just had a paper in the New England Journal discussing this. I mean, it's knowing whether Omicron is less severe or it's just as a background of more immunity is difficult.
Thank you.
Greetings, everyone. Dr. Swerdlow, this is amazing talk, quite a good historical perspective as well. I had a question regarding you were talking about pyramid models. There you were using different type of multipliers and underreporting levels. Where are those numbers coming from in your model? Are those like Delphi methods or some kind of modeling that is being done for that multiplier, for example?
That's a great question. And maybe I should have shown that. I could share that paper, but we used as many sort of real data points as we could for each of those to understand the different levels. And so during H1N1, we set up surveys of 10 states, and we called people up and we said, have you had respiratory illness? If you did you go see the doctor? Did he do a swab? And then we had to use other methods to think about whether it was reported or not. But we tried to have, real data for each of the levels of the pyramid. What proportion of people go to the doctor? What proportion of the people get a swab? What proportion of those get So the papers have that described. But yes, I don't think we ever had to use the Delphi method. I think we always try to use some other way of, and each of those layers added some uncertainty to the estimates, but we did some Monte Carlo modeling to try to take that into account. But yes, we tried to have data for each of those levels.
I see. Thank you.
Thank you for that. And Jeffrey?
Hi, David. Thanks so much for that talk. Really interesting to hear you talk through all those papers. Like many folks, I thought there was too much optimism regarding the potential of infection and vaccination to provide longstanding immunity early on in the pandemic, particularly because we knew this was a coronavirus and coronaviruses evolve and prevent longstanding immunity on a short term. We have like multiple examples of close relatives. They all do that. And analysis by phylogenetic approaches shows the same thing. Do you agree that there was too much optimism? And how could we better inform decision-making and public messaging in cases of future zoonotic pandemics?
Yeah, no, I think it's a great point. I think there was some optimism that we would reach herd immunity levels and that would be the end. In Israel, Mark Lipsitch was working with us, and we actually set up a whole project to predict if there was waning immunity from vaccination, when disease would come back. So we were cognizant that that was a possibility, and we started doing a model to say, what it would look like and when it would happen and all that. And we never got a chance to finish the model because the pandemic came back, which gave us the answer. So no, I think it's important to think through. Hopefully there's still immunity against severe disease, but I think a lot of people have been disappointed. We were sort of hoping to get back to our normal lives after vaccines.
Yeah. Optimism is what we all want to have, right? I just think in this case in particular, we know a lot about coronaviruses. Callow did these experiments in the 60s showing that if you infected someone with the same strain they got 2 years ago, they didn't get sick. But if you infected them with a strain that was going around that year, they did get sick, just challenge experiment. And then we also have years and years of surveillance data. So I just wonder, I just feel like this is, I'm interested in doing this in part, but how we can sort of get this into the common consciousness that you don't have to rely on empirical data to have a good idea of what's going to happen about a particular virus if it's a close relative of other viruses that we know about. A lot of times in this pandemic, in the most recent pandemic, a lot of people always referred to flu as the comparator. And I always felt that was a really inappropriate comparator for what we're doing in this disease because, the coronaviruses are not closely related to flu. They're very different beasts, but they're very closely related to each other.
Yeah, I don't think MERS and SARS-1 were great. It didn't teach us a tremendous amount about SARS-CoV-2. They were different in some senses, but maybe seasonal coronaviruses might have been a better model for thinking about immunity and long-term immunity and that kind of thing.
I don't see any hands raised at the moment except for Madhav's. So I'll let Madhav round us up here.
Okay. First of all, thanks again, David, for joining us. It was just a superb talk, and the breadth was astonishing. I have two questions. One somewhat technical, or at least, and then second is a general question. The first question has to do with the trials themselves. I don't know that many folks. You're the person I know, I guess, most now in terms of being closely involved in these vaccine trials. So it strikes me that there has to be a way to speed up these trials. And I do not know how it's done right now within, say, Pfizer. Of course, from the published papers, it appears a lot of randomized trials are done, but this has been a pet question for our group for a while on how one might be able to do these trials, which are somewhat faster and don't have to use typical randomized versions. On the other side, my question is to sort of get your input from the experience you've had at CDC and all these years. Did you anticipate the level of hesitancy with vaccines that we have seen during this round? I, for one, would have never thought that we would have such an amazing level of challenge thrown at us. Once the vaccines were there you would have thought this is, people who have taken it like it's been done, say, in Denmark or other places. But so
yeah, no, so at CDC, we thought a lot about pandemics. We did a lot of tabletop exercises. We did tabletop exercises until we were blue in the face for pandemics. But one of the things about the tabletop exercises is that they had these former generals, actually, they really were former Army generals and stuff, running the exercises. And they would give us these things called injects. And it was like sort of how you did the tabletop exercise. You'd get an inject and it would come to your desk and it'd be like, so-and-so, the senator from Nebraska, has a grandchild who has a cold. It could be flu, but he doesn't want to use oscillate. It were these ridiculous scenarios. And then you had to like create guidance and figure out what to do with it. That was what the exercise was. And we always used to say that the injects are ridiculous. They were trying to be ridiculous, But in the wildest inject, in the wildest, in our dreams, we never could have predicted that the things that happened during this pandemic, just in terms of the country just dividing in two between us versus them, and us is face masks and lockdowns and vaccines, and they are hydroxychloroquine and ivermectin, and the country just divided in two in a way that with vaccine hesitancy, and it's just I don't think anyone could have guessed that would have happened. In terms of rapidity of the trials, I think the trials were pretty amazing. And, we were able to get this vaccine to market so quickly for a bunch of reasons. One is that we did everything simultaneously. We had multiple arms at the beginning of the phase 1. We had different doses, different times in between doses, different age groups, it was just, we just threw everything at it in a way that normally you would go one step at a time. Instead, we simultaneously went for multiple age groups, multiple doses, that kind of thing. So I think we were able to do the trial much quicker than normal. And the other thing was the FDA was working with us every step of the way. Normally things could take 6 months for them to review your paperwork, and they were doing it practically real time. I think that things did go just about as fast as you could expect. Normally we always say it takes 10 years and $1 billion to make a vaccine. And so this took 1 year, and I don't know how much it cost, but everything was done simultaneously. By the time the clinical trial was over, we had vials ready to go out the door. That never would have been like that normally. Normally you finish your clinical trial, you give it to FDA, they come back 6 months later, they say, okay, you can use your vaccine. You manufacture it, you start selling it. Everything was just done in an amazing way. It was much quicker. I don't know how to do it much quicker than they did it. Of course, having, what people are talking about having vaccines for all of the potential pathogens, at least through phase 2, and just ready and sitting there, I think could speed things up a lot. And, we had SARS, we had MERS, we could have gotten further along on a vaccine, but when the media goes away and CNN goes away, people stop working on vaccines. And so that's what happened with SARS, and that's what happened with MERS.
Thanks, that's very useful.
Thank you. There is one more question from Chris. Chris?
But let me just ask this question. It's related to what you just talked about, but do you think that there's an important place for new research in understanding how all this information can be brought to bear and understand decision-making, or understanding how people at all levels in this system, if you want to think of it that way, people, individuals, people in the pharma, people in government, people in universities and medical schools, think about the decisions they make in these environments? It seems like we've missed something important about understanding how people integrate information for their own purposes when they're surrounded by it in ways that are maybe innovative now, different than they have been And you said it was unpredictable. I think in other environments, military environments and others, it was probably a little more predictable. But this environment, maybe financial environments, other sorts of things, do you think that there's a place to really look at these individuals that were so unpredictable and understand better how to provide information to them to account for the things that they have to deal with to behave differently?
Yeah, I think that's absolutely critical. I think our whole society has to understand the influences on vast numbers of people and really understand social media and understand political forces and get to the bottom of why certain people do some things and certain people do other things. I think it's, I think there's a lot of disinformation, but I also think there's, other political forces. I think that's critical to understand. How to get people vaccinated it should be basic, but instead having to go back to the drawing boards and really understand what are the motivators and what is the disinformation and that kind of thing. So I think your point is a great one. I do think that's an important area of research.
So on that note, thank you once again. I'm sure everyone really enjoyed this talk. I could tell it was a great choice of topics and very appropriate for this audience.
No, I appreciate it. It was very enjoyable for me. And actually, I've been wanting to put together a talk like this for a long time. So this gave me motivation. So I thought it was interesting to see some of my old friends on the list here. Thanks
again.
Thank you. Bye-bye.
Bye.